Hello, today I'm going to do the second part of the infant examination. Alright, so have here our baby models. So I have to close the mouth and occlude one of the nostril. An infant is a nasal breather. Okay, then I'm going to check for the nasal septum. So the nasal septum is midline. Then as for the mouth, I have here a tongue depressor and again my pen light. So a tongue depressor is inserted. There should be no cyst, no teeth yet at this point. Infant's mouth is edentulous and the alveolar mucosa is smooth with finely serrated borders. Then let's proceed to palpation of the upper part palate. So I'm ready, guys. Okay, so I'm going to insert my finger here. I'm going to palpate for the hard palate. So the hard palate is intact. And I was also not able to palpate any cyst in the mouth. Next, I'm going to palpate for the neck. So I'm trying to check if there are lymph nodes or swollen lymph nodes on both sides. So no lymph nodes on both sides. And I'm palpating for the clavicles. The clavicles are not fractured. For the thorax and the lungs, so it's best to do this inspection or examination when the baby is not crying, the baby is not distressed. There's a pattern of a rapid and slow breathing, which is called periodic breathing. This is normal in infants. The infant is a nasal breather. I was not able to hear any grunting nor audible wheezing. There's no nasal flaring or retractions that can suggest that the baby is in distress. Next, we're going to palpate for the tactile fremitus. It's best felt when the baby is making sounds. Then let's proceed to auscultation. So for auscultation, the infant's breath is usually louder and harsher than the adults. So let's hear it. Okay. So there's no wheezing, crackles, nor ronchi, or any adventitious sound. Let's proceed to the heart. So for the heart, I have to check for signs of cyanosis, looking at the mouth area, the hands, also the feet. So there's no cyanosis. And at this point, the PMI is not detectable. But you can try to feel for the thrills using the palm or the base of the fingers, so no thrills. Then let's proceed to auscultation. For auscultation, first I'm going to use the diaphragm. So I'm also going to use the bell of my stethoscope. So at this point, it's normal to detect sinus dysrhythmia, where the heart rate increases with inspiration and decreases with expiration. As for the breast, so checking for the breast, it's normal for infants to have enlarged breast due to the mother's high maternal high estrogen. It's also common, or not really common, it's also normal to see whitish liquid, which we colloquially call as witch's milk, and it usually lasts for the first to second week of life. As for the abdomen, so the baby's abdomen is normally protuberant due to the weakened abdominal musculature. So we also have here the umbilicus and the umbilical cord. There are two umbilical arteries and one umbilical vein. It's not red, it's not swollen, and no abnormal herniation. Then let's proceed to auscultation. So on auscultation, it's normal to hear tinkling bowel sounds. There should be no increase in frequency and pitch. Then let's proceed to the last part of palpation. So to relax the infant, we have to flex the knee and the hip area. So we flex the infant's leg, then try to palpate. Okay, then to palpate for the infant's liver edge, we start at the lowest part of the right costal margin. So it's usually 1 to 3 centimeters below the right costal margin. For the spleen, it's usually to the left side, it's 1 to 2 centimeters below the left costal margin. So this ends the second part of the infant's examination.